I talked about this TellWatch monitoring system. This is a system that was developed by Hopkins Applied Physics Lab. It's a remote monitoring system that can track physical biometric data and some symptom-based questions. And then, like I said, working with all the members of the healthcare team. And this includes anybody. This is home care, any DME vendors. You know, behavioral health is critical to this. Because again, if you have a member who has chronic illnesses but also suffers from substance abuse and diabetes, you may not get them engaged with monitoring their blood pressure, their diabetes, if they're not managing their substance abuse or mental health, depression issues, etc. So more on TellWatch. Like I said, this is an automated telephone-based monitoring system. And how we do this is we provide them with the durable medical equipment that they use for their particular condition, if necessary. And the reason why I say that, we've expanded the question sets with this. But we can provide a scale, a glucometer, and a digital blood pressure cuff. So they can take those numbers, and then they can enter them into their telephone, and then it goes through a path where it transmits into a server. Or there's symptom-based questions that are based on an algorithm. So sometimes if they answer yes to something, then it branches off into another set of questions. We've worked with our providers. We have physician advisors for all of our programs. We have our medical directors. And what we've done with them is set up alerts within the system, and then and I'm saying the nurse because in this situation we use the clinical nurse case managers, particularly to monitor some of these physical parameters. And for an example, let's say that you have a congestive heart failure patient and you've given them all the necessary equipment. And Friday they put a weight in, and it was okay. And then Tuesday morning you go in and look, and they gained 5 pounds over the weekend. Well, the first thing you do, you saw that on the alerts. So the first thing you do is you call the member, and they say, well, yesterday was the Redskins game, and we had a party, we had pizza, we had pretzels, we had nuts, we had beer, a lot of salt within the diet. So, you know, at some point you can say, this is unusual for you. The high sodium intake could have attributed to that fluid overload, you know, and the increased weight gain, and then we have the ability to communicate that information to the providers. So these are some things that we can monitor through that system and otherwise, because we have the data down there. Because we have pharmacy data, we can look at their medication use, their adherence, we can look at their persistence ratio, and oftentimes this is useful information for providers because you may give them a prescription, and if you don't see them within a certain time period, we can determine if they're getting their refills as necessary. That's something, you know, you may not have that information at your fingertips. We look at any exacerbations, like I said, any clinical deterioration. We look at their utilization. We have, and this is a report that transcends at least two of the levels. We can look at their ED utilization. And we look at frequent flyers to the emergency room, and we have reports that can be given to the providers so you can track that information also. We are checking to see if they're keeping their appointments. And like I said, are they adhering to their goals? Immunization history, flu season is coming up. You know, you have some very chronic complex members in there that need flu shots. And we also, like I said, test requirements and results. And this is something we may be contacting you for. We may want to know what their A1C is, because if we have not yet collected it through lab data, how do we approach somebody with an A1C of 9 versus 16? So our interventions would be different based on that. So this is our lovely TellWatch system, and like I said, we can track some of that data to include some of the pharmacy and some of the physical parameters. So the way that it works is we've given the member the equipment. They're right here. They self-collect the information. They enter it into the telephone. You have to have a touch-tone phone. I don't think anybody has rotary anymore. If it's a blood pressure, we tell you to put in the top number first and then the second one. Then it goes into transmitted into there. It goes into the POTS line, and this is, I didn't make this up, this is a plain old telephone system line, which then goes into one of the servers down in Glen Burnie, and then it shows up on the case manager's laptop. And then the other nice thing about this is we can print reports, which we can give to you, the provider. So we collect a lot of data, and we need a lot of data. So I already talked about, you know, how we use it to identify members. You know, we can help analyze our population. We do like to, like I said, even for the member itself, we want to look to see what their lab values are, you know, what their medication usage is, you know, is their blood pressure elevated. For our different programs, we have different outcomes that we target. So if we have a pregnant mother, we want to look at what the baby's birth weight was. Did she carry this baby to term? Was it a premature baby? For a complex member, did they get their flu shot? For HIV, what's their CD4, their viral load? And I already mentioned how we can look at some of the utilization outcomes. And, you know, like I said, the intent is, like I said, trying to improve these so that we keep them out of the hospital less in the ED. And like I said, satisfaction is important to us also. So diverting a little bit before I come down the pyramid, the utilization management area. People will say, I sent something to care management. Well, as I said before, care management is a big department. For the provider intent, these are the different areas within utilization management. So your inpatient team is a group that does pre-authorization, let's say for elective surgeries, or follows concurrent review while the members are in the hospital to say that it's appropriate that they stay there or not. Intake services, any of you who request any services, whether it's and approved services. So Ray talked about, you know, what needs pre-authorization and what doesn't. These are services that need an authorization, so this is a central point of entry for them within the department where they come. If it transcends the benefit and it has to go through a review process, there are registered nurses that constitute the medical review team who work very closely with the medical directors in terms of coming up with a decision as to whether the service will be approved or not. And transitional care, now again, this is a new, not a new term, fairly recent term in the literature, because they have found that as members transition between different areas, that's where gaps in care occur. So as they move from a hospital to a subacute, to a SNF facility, and then home, there's got to be a smooth transition because often the message gets lost in transmission. So as they leave inpatient, there are utilization case managers within UM who transition them from one setting to another. And they're doing more of an inpatient setting, so they go from a hospital to a subacute. On the other side, we have a program called Welcome Home, which is also transitional, and that's where we work from hospital to home. What we're trying to do is to prevent any lack of transmittal of information regarding medications, follow-up, et cetera, so it's a smooth process. A lot of that is medication reconciliation. And also under the umbrella of utilization management, it doesn't seem like it belongs there, but it's our behavioral health department. This is different by line of business, and the reason why I say that is for EHP and USFHP, the behavioral health department monitors and assists both with substance abuse and mental health issues. The state of Maryland has carved mental health out for Medicaid for the Priority Partners line of business. So for the Medicaid line, the behavioral health department only does substance abuse authorizations. However, there are employees within the department and also in the other parts of care management that will assist them with coordinating some mental health services. We have a group called Special Needs Coordination, and again, this is kind of a central point of service. I'm going to talk about this twice tonight, but they act as a liaison, and this is primarily for the Medicaid population. COMAR, which is the Code of Maryland regulations, require that you have this, and it links the member providers and different agencies, and they also assist with interpreter services. Interpreter means both sign and language, and for any of your Medicaid members, if you need these services, the only thing that we ask is that you give us at least 48 hours notice because we have to arrange that with the vendors that provide these services to have them come to the provider's office when needed. I mentioned earlier about social work, and like I said, this is 2 years for us. And recognizing the fact that not just with Medicaid, because actually we have used the services both for all three lines of business, is that if they have non-health related issues, what are they going to focus on? So if it's no food in the house, can they worry about what their glucose level is? So the thing is to quickly target that issue so that you can then focus on health related issues. They cover such things as assisting with housing. What if you sent in a referral for, you requested something that's not in their benefit structure? So the social workers do their best to try to see if they can find alternative resources within the community to assist with that. I already mentioned food. Domestic violence is huge also. They are now handling, helping with assistance with transportation, particularly those who need medical transportation